Hello everyone. Today going to talk about a very common cancer. As in this series, we are talking mostly about bowel problems. So the five commonest cancers around the world are skin cancer is obviously very common. Lung cancer, second commonest because mostly because of smoking. Um, Prostate cancer in men doesn't happen in women, obviously. Breast cancer more common in women as compared to men, but again a very common cancer in ladies. And today our topic will be talking about colon cancer, also called bowel cancer or colorectal cancer. Let's first of all just refresh our memories about what the anatomy of the colon looks like. So in the black, I've drawn the abdomen. So that is the belly button or the umbilicus. That is the rib cage at the top, and this is the pelvis that we can all feel the bone at the bottom on both sides. This is the right side of our tummy. We are looking at it from the front, and this is the left side of our tummy, and that is the bottom end, what is called the anus or the anal canal. So if you start from the right side of the tummy, right below the belly button on the right side above your bone, then there is our appendix, which is attached to the first part of our colon, which is the largest part of the colon called the cecum. Going upwards, this is the ascending colon, which is ascending means going upwards. So ascending part of the colon that is going across or transversely across the tummy called the transverse colon. Going down means descending, so this is the descending part of the colon. Then it twists around like a comma, so like a comma, and that is called the sigmoid colon, like a comma. And the last bit of the colon at the bottom in our pelvis is the rectum. So this is the colon proper, and this is the rectum, which is the bottom end of the colon. And that is the anal canal through which our poo comes out. So I have labeled this quickly. So cecum, ascending colon, transverse colon, ascending going upwards, transverse going across, coming down is the descending colon. One that twists like a comma is the sigmoid colon, and the bottom end is the rectum, and down below is the anus. So one more thing to talk about very briefly is if I draw a line across here, so this is where the bend of the colon is on this side, and there's a bend of the colon on this side. Now over here sits the liver. So if I draw a liver up here, so liver sits up here, very big organ, biggest organ in the body. And over here sits the spleen, like this. So spleen and liver. Now, as most of you know, the liver, anything to do with the liver is called hepatic, and anything to do with the spleen is called splenic. So this twist in the bowel, a twist or a turn in the bowel, which is called a flexure. Flexure means a twist or a turn, basically. This turn in the bowel over here is called the splenic flexure because it's next to the spleen. Spleen just literally sits on it. And on this side, it is called the hepatic flexure because the liver sits on it, because anything to do with the liver is called hepatic. So hepatic flexure and splenic flexure. So if you draw a line across the splenic flexure, everything below it, the part of the colon below it, is called the left colon, rectum and the left colon, and anything before it is called the right colon. The reason I divided it into two is because the symptoms are slightly different in the left colon as compared to the right colon. So I've tidied up the photograph a little bit, my drawing is the thing to look at now, how do bowel cancers develop? Now the commonest part where bowel cancers develop and how they develop is from polyps. The polyps are little growths in the bowel, like we get spots on the skin or moles on the skin. Similarly, the bowel get little spots or little growths inside the lining from the inside lining of the bowel. Now some of them looks like little mushrooms. Some of them look a bit flat like little mounds or little mountains or hills on the lining of the bowel. Some of them look like fronds, like seaweed on the bottom of the sea. Looks like that. And these, if some of them, if left alone, not all of them, some of them left alone, as they grow in size, the cell changes on the surface and they eventually can turn into cancer or bowel cancer. So let's talk about the symptom that one can get from bowel cancer. So I've drawn different types of cancer. This is one is in the rectum, so that's the rectum. One in the rectum. I've drawn one like seaweed, quite a bit, quite big one in the sigmoid colon. I've drawn one in the descending colon, which is like constricting around like this. So the hole in the bowel is becoming very narrow. You can see the hole in the middle of the tumor is becoming very narrow. Some cancers I've left very, very small. And one on the right side, I've drawn like a big mushroom shaped or a cauliflower shaped cancer on the right side of the colon. Now, if you look at them, they're quite self-explanatory that how will they present. Cancers which are so tiny, although small polyps don't easily get cancer, not many of them cancer, but some of them can develop cancer cell quite earlier on, even when they're very tiny, like size of a bean or even size of a pea, like a centimeter or half a centimeter. However, it is quite unusual. So chance of getting cancer is much higher when the polyp size increases. So 2 centimeters and over, the chance of getting cancer is much higher, like an inch or bigger. So if you can imagine somebody has got a cancer only this size, the symptom they will get is probably almost none. Their bowel activities will be normal, they'll have no pain, hardly any symptoms whatsoever. If you come on the left side of the colon, just before I go on the symptoms, one thing just to briefly touch on, that is our small intestine. So our food and everything after digestion comes into from the small intestine into the large intestine, or the first part of the large intestine, which we call the cecum before. When the food contents come in here, they're quite liquidy. They're almost like thick water. And when they go up, up, up and across the bowel is like a sieve. The colon is like a sieve. So things filter out of it. Like if you put something in the sieve, like mud in the sieve, the water will filter out of it. Similarly, from this colon, the water filters out. And as the bowel contents or things in the bowel go further down the line, they become thicker and thicker and thicker and thicker. So by the time they come to the left colon, they are solid poo. So watery in here like thick mud, water comes out, comes out, comes out, comes out, and all that is left is thick solid poo. Yeah. So the chance of something blocking thick mud is much less as compared to something blocking the solid poo is much higher. So something which is making the bowel narrow on the left side will cause blockage of the colon much earlier, or partial blockage of the colon much earlier, because what is going through is quite solid. If you put the same thing on the right side, because the contents are very liquidy, like thick mud, they will not block easily because the fluid contents will just sneak past it. This has to be quite big or very close to the opening with the small intestine to block this completely. So the blockage of the bowel on this side can happen, but not as common as on this side. Now when the blockage is happening on this side, the bowel is getting narrower and narrower. You can see the lumen in the bowel is much smaller. What happens that first thing the patient complains of is change of bowel habits. Yeah. Now change of bowel habits is the bowels, instead of going once a day or twice a day, what is normal for someone, it changes. So they start getting, because the solid poo can't get through, it stops here. So solid poo will come and it literally stops here. So patient is getting a blockage, nothing is going through. But then pressure builds up above this blockage, and the dam breaks. Everything, once this goes through, everything above the blockage comes out like a gush. So they get like a diarrhea. So they get flipping between constipation, something blocking, and then everything gushing through diarrhea. So they flip between constipation and diarrhea. Second thing that happens, especially if the tumor is like a seaweed-like tumor, they secrete a lot of mucus, a lot of slime, like thick, snorty slime that comes into the stools. So that is another symptom of bowel cancer. Also, if the tumor is quite close to the bottom end, like in the rectum, they can bleed because every time poo go past it, it causes damage to it and it bleeds. They're quite friable, they're quite frail. They scrape easily, so they bleed easily. So the patient complains of blood not separate from the stools but mixed with the stools. So stools comes in, or the blood lining the surface of the stools. So when the stool scrapes across here, the blood smears the lining of the poo, or if the bleeding is up here, it's mixed with the motion by the time they come out. Now, one important thing to understand of tumors of the right side is because the bowel contents are very fluidy, they don't block easily, so change of bowel habits don't always happen very early. They can happen once the blockage is complete. However, they don't happen very early. As I said, the tumors are quite friable, quite frail, they bleed easily. But when bleeding happens in the right side of the colon, by the time the poo comes out, the blood cannot be seen under the you have to look at it under the microscope or with a special stool test which looks for minor bleeding. However, this minor bleeding, if left over many months, can give rise to low blood count, anemia. So one of the symptoms of right-sided tumors, anywhere over here, right-sided tumors, is the patient loses blood slowly and they become anemic. As we know, the tumor becomes bigger and bigger. Tummy hurts, is getting blocked, partially blocked. They get gripe in the tummy, bleeding, etc. It puts them off their food. When the patient is off their food, they start losing weight. So the symptoms of change of bowel habits, diarrhea and constipation, abdominal gripes, tummy pain, bleeding from the bottom end, especially blood mixed with stools, or blood smearing the surface of the stools, slightly darker blood, or anemia or blockage of the bowel. These are all the main symptoms of bowel cancer. So the next question is, what will put us at a high risk of developing bowel cancer? Bowel cancer can happen in any age, but as we grow older, the risk increases. Like most cancers, it happens. So over the age of 50, and certainly over the age of 60, vast majority of patients with bowel cancer, over 75-80%, will be over this age. If you are in USA, then African Americans have a high risk, and in other parts of the world, certain ethnic minorities have high risk of developing bowel cancer as compared to others. If somebody had a previous history of bowel polyps or even a bowel cancer, they are at a much higher risk of developing a second bowel cancer or more polyps which can turn into cancer. Patients who have a long-standing history, more than 10 years onwards, of Crohn's disease or colitis, which we have discussed in my previous videos, they increase the risk of bowel cancer. There are a couple of congenital conditions which mean they're transmitted from family members to the next generation, to next generation, to next generation. One is called HNPCC or Lynch syndrome, which stands for hereditary non-polyposis colorectal cancer. And this significantly increases the risk of bowel cancer, especially if they have that gene present in their system, then they will be at a very high risk of developing bowel cancer and certain other types of cancers in the body as well. And these people can be screened for not just developing bowel cancer, but for the screen, and a treatment can be offered to them well in advance of actually developing bowel cancer. The second condition is called familial adenomatous polyposis, or FAP. Again, there's a gene problem. Gene is not working properly. They're not born with that gene. Again, runs in the family, and these patients develop hundreds, or if not thousands, of polyps in the colon and other part of the digestive system, and these can turn into cancer at a much younger age as well. So two main risks. Other thing that can contribute to developing bowel cancer, it's been shown that people who have low fiber and very high fat are at a high risk of developing bowel cancer. Obviously, people who don't have sedentary jobs, which are sitting down for a long period of time, rather than active jobs or active lifestyle. Obviously, obesity comes in the same category as well, because people are not active tends to put on more weight. Um, Not all the time, but sometimes they do. Diabetes again increases the risk. Smoking, excessive alcohol, and radiation treatment. Radiation treatment, like many cancers, are treated with radiation, like prostate cancer, testicular cancer, lymphomas, especially on the tummy when the radiation is given, and that exposure of the bowel to the radiation over a long period of time can increase the risk of bowel cancer. So those are the few risk factors that I could think of. Before I go into mentioning how colon cancer is diagnosed, what tests are done to diagnose colon cancer, one thing I forgot about to mention in the symptoms of bowel cancer is when there is a tumor in the rectum, like I drew before. So if I draw a tumor in the rectum over here, then sometimes what patients feel is there is something in the bottom end they want to clear. So they want to go to the toilet again and again and again, but nothing comes out, or very little comes out, a bit of slime or mucus comes out. That's a symptom called tenesmus, and again, a symptom of colon cancer, especially rectal cancer. Now, the second thing we are going to talk about is how is colon cancer diagnosed. When a patient goes to the doctor with the symptoms of, say, change of bowel habits, abdominal pain, weight loss, tenesmus, or anemia that we talked about earlier, then the doctor obviously, to start off with, do some routine tests like blood tests, stool tests, etc. Stool tests might be to check for blood loss, as I mentioned earlier. It could be to check for inflammation in the bowel, infection in the bowel. Blood tests could be to check for anemia, etc. However, there are two main ways of diagnosing bowel cancer: to look at bowel cancer and to diagnose bowel cancer. And after all those tests are done, the doctor might plan to refer you to for one of these tests. Now, the first test is endoscopy, and there are two different types of endoscopy I'll speak about in a second. And the second is a CT scan, or also called a virtual endoscopy or a colonoscopy. So let's talk about endoscopy first. Endoscopy, as we know, is a camera test of the intestine, whether it's the top end or the bottom end. To diagnose bowel cancer, there are two different types of endoscopic procedures available. One is called a colonoscopy, one is called a sigmoidoscopy. Now, as we discussed before with the anatomy, sigmoidoscopy means the camera test which goes from the bottom end and checks only the bottom end of the bowel, which is a sigmoid colon and the rectum. This test is relatively straightforward and simple. So patient comes to the unit or at home, give themselves an enema. So from below they give themselves an enema, or if they can't, then when they come to the endoscopy unit, the nurse gives them an enema, and it cleans the bottom end out of all the poo, and a short camera is put in without any sedative or anything required, because it can be uncomfortable, but not very painful test. And the camera is put in, and if the tumor is either in the rectum or in the sigmoid colon or lower part of the bowel, then the camera will be able to pick it up. However, if the tumor is higher up, somewhere say in the transverse colon or in the cecum or elsewhere over here, with a limited camera test can't go far enough, then a colonoscopy is performed. Colonoscopy, most of you know, is a full camera test of the bowel. And although not every patient is suitable for a colonoscopy, because sometimes colonoscopy can be very tricky and difficult to go around, possible in about 9 out of 10, 9.5 out of 10 people, so 90-95% success rate of the colonoscopy. Any procedure can have risk with it, like injury of the bowel, bleeding, etc., but the risk is relatively low. So in colonoscopy, the preparation is different than a sigmoidoscopy, because a very strong laxative is given to the patient to drink at home a day before with a special diet, so they have a totally clean bowel when they come. And a long camera is put in, usually under sedative or gas and air, to control the discomfort and pain, because it can be an uncomfortable test because a long way going in. And with that camera, they can find the polyp or a tumor, and they can take some biopsies. And if it's an early polyp or early cancer, they can even remove it with a camera test. So the second way of diagnosing bowel cancer is with a CT colonography or a virtual colonoscopy done through a CT scan. So The patient again a day before is given a special diet and a laxative, so clean the bowel out. When they come to the X-ray department, because CT scan are done in the X-ray department, they lie on a table. In the bottom end is placed a small tube through which air is pumped into the colon, and the CT scan is done, and the CT scan makes 3D images to tell what is in the colon. Is there anything worrying? Is there a polyp, or is there indeed a cancer in the bowel? Before as well, in my previous videos, whenever we talked about cancer like esophageal cancer, stomach cancer, or any other cancer we spoke about, there is a thing called staging. As we talked about, staging, again to summarize, means that how early or how late the cancer is, because the treatment changes. Early cancer has more chance of cure, late cancer has less chance of cure. And early cancer can be treated by smaller amount of treatment as compared to late cancer. Late cancer might require more treatment or might not even be suitable for treatment. So how do we stage bowel cancer to see whether it's early cancer or late cancer? There are three main ways. CT scan is the main scan used to stage bowel cancer. So CT scan is done not just of the tummy but also of the pelvis and also of the chest. The reason of doing the chest and the tummy is because, as we know, cancer can spread, and one of the places bowel cancer can spread to is the lungs and the liver. The second way of scanning is MRI scan, which is basically done for rectal cancer to see how early or late the cancer is, and usually limited to cancer of the rectum. PET scan, which is a positron emission tomography scan, is not very commonly used, but in a small percent of patients when doctors are unsure whether the cancer has spread very far or in unusual places, then a PET scan can be done. But these are the three main types of scans done to stage bowel cancer. So what is the treatment for bowel cancer? There are three main ways of treating bowel cancer: surgery, chemotherapy, radiotherapy. In a small percent of people, if a cancer is present in a small polyp, like say this one, a camera can be put in, a colonoscopy, and can be removed with a camera as well. And if it's a very early cancer, like only few cells of cancer on the surface and the rest is all benign, then no further treatment might be necessary for that patient. However, most patients with bowel cancer will require one of these treatments or two of these treatments or maybe all three of these treatments. Surgery, which these days can also be done with a keyhole. In vast majority of patients can be done with a keyhole, called laparoscopic surgery, in which part of the bowel is removed where the cancer is. So for this part of the cancer, only half of this bowel needs to be removed. For this cancer, only this part of the bowel needs to be removed. For this cancer, only this part of the bowel needs to be removed. For this cancer, only this part of the bowel needs to be removed. So that is surgery. Now, many of these patients who have very early cancer, so it has not spread into the lymph glands or elsewhere, surgery is all they need. However, if there is any doubt that this cancer is spreading into the lymph glands or elsewhere in the body, then chemotherapy is also put on top of surgery, either before surgery or after surgery or both. Radiotherapy or X-ray treatment is usually given for rectal cancers, especially before surgery, because it shrinks the cancer down and makes surgery much easier and makes the cure much higher. In some patients, an emergency surgery may be required because either the tumor is too advanced or the patient is not fit enough to have a major operation or have chemotherapy or radiotherapy, or as an emergency they come with a blockage of the bowel completely and nothing is going through, and you have to perform an operation in the middle of the night because they're too unwell. So in that case, a bag might be put on the tummy, a colostomy or an ileostomy to get the poo out, so the blockage and gets better and the emergency gets over. In some patients, after surgery as well, when part of the bowel is removed and the two ends cannot be joined together safely, then, or if they are joined together, they are not completely secure joint. So to protect that joint, a surgeon might have to put a bag on the tummy called a colostomy or an ileostomy, which can be reversed in a few weeks or in a few months' time. I hope you found this video useful, and I'm most grateful to you for watching. And please watch my following videos and previous videos as well. And please remember to subscribe.